Thank you very much. Thanks for the introduction, PJ. All right, so I know it's been a long day and everybody's tired, so we'll just jump right in. PJ already announced the title. I have nothing to disclose. I'll just leave it at that. So what is process improvement? So process improvement is a systematic approach to help an organization optimize its underlying process to achieve efficient results, basically. And the American College of Surgeons Committee on Trauma, ACS-COT, really sort of mandates that each trauma program demonstrate continuous process improvement. And how we do that, you know, we monitor things, assessment, management, directed at improving care. And again, we want care that's safe and efficient and effective. And then, so what's quality of care? Because I don't think you can talk about process improvement and not talk about quality of care. I think everybody, you know quality when you see it, sort of. If you're at a hospital, you can walk away and you can say, wow, that's really good care. You know, the doctors were great, the nurses were great, the hospital atmosphere. I think we know quality. We may not can like give a definition on the spot, but I think we know it. The definition from one of our popular dictionaries is quality is the degree to which health services for individuals and populations increase the likelihood of a desired outcome and are consistent with current professional knowledge. And so that's quality. And, you know, as we know, quality is a big buzzword in everybody's hospital. Just the word quality has made a bunch of jobs for people. Where do you work? I work in quality improvement division. So quality, you know, it's a big thing and it's come around. So when did quality in healthcare sort of become a major focus? Well, in 1999, with the Institute of Medicine, is when it sort of got its publicity, if you will, with the report To Err is Human, all right? And in this report, after a lot of discussions with a lot of people, I think there's like over 50 people on the board of the Institute of Medicine from all walks of life. Patient harm is not sequela of good intentions, competence, or bad intentions. In other words, they were starting to look that we do cause harm to patients, but not because we were trying to, or not even if we had bad intentions, or not because we're competent. That safety in healthcare is a direct consequence of a whole system of care. And so they came out with To Err is Human, building a safer health system. And the first Do No Harm, 1999. And they followed into about 2 years later with Crossing the Quality Chasm. And sort of some of the same beliefs, and this is blurry slide a little bit, but at the bottom, American healthcare delivery system is in need of fundamental change. The current care systems cannot do the job. Trying harder will not work. Changing a system of care will. So in 1999, Institute of Health came out with that, and then 2001, this Crossing the Quality Chasm. And they had these 10 rules, which I won't read to you, but the 6 aims were for it to be safe, effective, patient-centered, timely, efficient, and equitable. So there's this big growing interest in 1999, right, 2000, that, you know, formal quality programs are needed. And what was realized that although this growth is happening, that we need these formal quality programs, it soon became pretty realistic, or pretty known that there's a knowledge gap. So physicians are like, well, I'm already providing quality care. What do you mean we need more quality programs, you know? So there was this knowledge gap, and how do we do this? Because as far as we were concerned, and when I say physicians, nurses, all of us, we feel like we're giving quality care. And so there can be some lessons learned from the past. And again, like Dr. Kozar, she was a history buff, and she trained me, so I'm kind of a history buff. You know, if you look back in the past, in 1895, it's hard to talk about process improvement and quality without talking about Dr. Codman, Ernest Codman. So Codman was a surgeon, no surprise, he was a surgeon, established the framework for surgical outcomes assessment and social determinants of health. Now at the same time, there was another man named W.E.B. Du Bois, who was also at Harvard. These two were at Harvard together, and he was really into social factors and their role in health and healthcare disparities. So Ernest Codman came out with the end results theory. You can pull up and read about it. But basically he says, so I'm called eccentric for saying in public that hospitals, if they want to be sure of improvement, must find out what their results are, must analyze their results, must compare their results, and must welcome publicity. So you can imagine that cost him his career, his livelihood, everything, because this is, 1899, 1895. And at the same time, you have Du Bois saying that we need to make some changes, and now's the time to change, and there's all this inequality going on. So Dr. Codman, again a surgeon, treatment of unsuccessful or unsatisfactory, we should fix the responsibility for failure on the following. So we can't say we have a bad result and go home, okay, the end. So, and again, this is back in the late 1800s. You gotta fix the responsibility for the failure on something. Is it the physician or the surgeon? Is it the organization carrying out the detail of the treatment? Is it the disease or the condition of the patient? Or is it a social or personal condition preventing the cooperation of the patient? And again, you can, in my mind, I can see him and Dr. Du Bois working together and going through these things. And in 1906, Du Bois came out with the Health and Physique of the Negro American. He identified that the broader social determinants of health that were driving the poor health of the African Americans. And he documented this widespread inequity, sort of right along the same lines as Codman. Well, in 2002, however many years later, the Institute of Medicine figured this out. I guess they weren't reading the history books. I hope nobody's on the board in here. I don't mean that, literally. But it took till 2002 for the Institute of Medicine to say unequal treatment. So in 1999, we got to err as human and it may be safe. And then in 2001, crossing the quality chasm. And then in 2002, unequal treatment, that we've shown stubbornly persistent inequity in healthcare across all decades. So when we talk about surgery and quality, which gets us to process improvement, well, I think surgeons, we've been driving this forever. I mean, like I said, I started with Codman. He said it, he meant it, and he lost his whole livelihood for saying that we have to be responsible. And that's basically what he said. And so M&Ms really came from him in the early 1900s. In M&M, we go to a room and we look at every death and every complication, and we try to take personal responsibility. And surgeons started this in the early 1900s. And then some 80 years later, the ACGME, the American Accreditation for Graduate Medical Education, required every accredited residency program to conduct weekly M&Ms, to look at every complication and death. And then right around the time of the IOM report, the American Board of Surgery, ACGME, called for the integration of patient safety and quality training into formal education. So we went from 1895 to 2000, where everybody's really getting the picture. And again, I'm very proud to be a member of the American College of Surgeons, because that's where most of this started. One of the big things, I always talk about that, is ATLS. To me, ATLS really changed process improvement. This is the biggest process improvement program I know. And so how did it begin? It began with a disaster. Okay, most good things come from bad things. Most good decisions come from bad decisions. Everybody's heard all those statements. So the beginning to me is with ATLS, and everybody's seen this because everybody here has probably taken ATLS. But the key is another physician, he happened to be a surgeon, Dr. Steiner, flying with his family. They crash, the wife dies immediately. He's trying to save his 3 kids. He's doing the best he can. And when they get to the first primary hospital, the care was just horrific. And when he made a statement, when I can provide better care in the field with limited resources than what my children and I received at the primary care facility, there's something wrong with the system, and the system has to be changed. And he forged ahead, and he made this happen, and now we have ATLS, and ATLS is everywhere. I mean, this is a map, and this is all these colorful places. It's everywhere, and it is a process improvement program that has really changed the world. Now, this is my senior partner, Dr. Sevi Rodriguez, and when I first came to Phoenix, he does a lot of laparoscopicness and fundoplications. And my first year, I would go in and scrub on just about everyone, because he's like, oh, I'm doing this new approach. It's the posterior approach, and it's not anterior. You don't even touch the esophagus till the very end, And then he was telling me how he'd go home and play with these balloons until he perfected this procedure. To me, that's process improvement. I said, you were doing home doing what? Let me show you. If we get a balloon, I'll show you how I did it. And so he talked to me about it, and of course I stole it and tried to make a paper out of it, which we presented at SAGES. It's a laparoscopic distal fundoplication using a left posterior approach, minimizes esophageal injury, our experience, because he's never had an esophageal injury, knock on wood. But again, that's process improvement, and that's what we do all the time. So there's this challenge that we have with administrators, because administrators want us to do process improvement and all these things to improve quality. A couple of years ago, we partnered with administration, and although you can't see everything on this slide, I'm going to see if I can do this, because everybody's been doing it. The key is we improved intraoperative processes. When they partnered with the surgeons, we improved compliance, we improved the patient experience, and we decreased our readmission rate. And all we did was go talk to the administration, because they're coming to us, we have to do this, we have to do that. Well, then partner with us. Let us help you. Let us tell you the best way to do it, because we take care of the patient, and that worked well. Well, you can't talk about process improvement, and you definitely can't talk about quality unless you talk about data. So improved quality, we must be able to measure the quality. So if we don't measure it, what doesn't get measured doesn't get improved. So quality, for me, we have to understand there's two different types of quality. Data. There's two different types of data. There's clinical data and there's administrative data. And you really have to have a good grasp, an understanding of what kind of data you're looking at when people come to you and say, well, your data looks like this or your data looks like that. So clinical data is really derived from ongoing patient care. It's when we get a chart, or EPIC, but a chart, and you look through the chart and you have all these variables, and you look through how long was the patient intubated, et cetera, and we abstract the data either prospectively or retrospectively, hopefully more and more by trained reviewers. But there's only so many variables that we can pull out of the chart. Well, administrative data, if the administration presents their data, this data it was never collected for research. It's collected for administrative purposes, for transactions, registrations, record keeping, financial, et cetera. And so administrative data was collected mainly for purposes such as billing, operational management, rates for service. And there's a lot of challenges with administrative data. There's imprecision of the use of the diagnosis and treatment codes, absence of data points of interest, issues with coding, overcoding, undercoding, reimbursement, and compliance. And claims data can be inconsistent and it can be subject to interpretation. So there's this sort of balancing act that we have to do with administrative data and clinical data. And as surgeons, we want to look at the clinical data because we know if it's real, but we still have to balance. We work in the hospital with the administrators and we're trying to partner and do this together. So the best in the nation, this was an award that the NSQIP got, the National Surgical Quality Improvement Program, which I'm sure everyone in the room is aware of. Got an award, Best in the Nation. And when did NSQIP come out? 1980s, okay? 1980s, so way before all the Institute of Medicine. Again, the American College of Surgeons we have always been extremely forward-thinking people. And so we started this a while back. And then the National Trauma Data Bank, all right? The largest aggregation in the United States of U.S. trauma registry data ever assembled, all right? Came out of the American College of Surgeons. Participation is voluntary, used to be voluntary, and is one of the leading performance improvement tools of trauma care. So it's a big deal, the National Trauma Data Bank. And then now, also through the American College of Surgeons, now we have NSQIP, and everybody's aware of TQIP. The TQIP just had their meeting. I didn't go, but most of my colleagues did, and it's just growing. It's like a wildfire, and everybody's there. And it's mandatory. I think now, if it's not now, maybe it's next year or 18, but everybody needs to be on TQIP. TQIP, but TQIP is good. TQIP works to evaluate the quality of care for trauma patients. A lot of people are already on it. More people will join. And it provides feedback about performance, identifying institutional characteristics that your trauma or staff can implement. And it gives risk-adjusted benchmarking data. So you can look at your center and it's risk-adjusted and see where you are against your colleagues, because we all need that feedback so we can improve. And this is one of our last reports from, this says fall 2016, and so this is kind of what it looks like. They've got some newer graphs, but it really allows you to really dive into your data. So process improvement. I'll talk to you a little bit about our program with process improvement. So our program at John C. Lincoln, our process improvement program consists of a whole lot of things. Of course, we have TPIC, which is a monthly meeting where all the subspecialties come that participate in trauma care, from the hospitalists to the neurosurgeons to the ER docs, radiology, everybody comes. Then we have M&M Weekly, and then we have Trauma Operational Committee Monthly, where all the services come. The director of this floor, director of that floor, director of radiology, director of respiratory, director of nutrition. Everybody comes to the Trauma Operations Committee. We have grand rounds that usually stem from a process improvement project. We have daily rounds. We walk around the unit every morning at 7:30 as a team. Unless you're off, we walk around with the residents and just to see what's going on. You know, what did we miss? And that's not a formal round, but it's an informal walk around that happens every single day, Monday through Friday at 7:30. We have monthly journal club, and most of the articles we review are as a result of some process improvement. Every week, the manager of, really the director of our PI program and I sit. She finds me some point in time during that week to do some chart review. So we look at the charts, right? And we just don't have walk around rounds in the ICU. We walk through the ER. We have G60 on the floor 3 times a week. So these walking rounds, I think, are a huge part of your program. We have people that at 6:30 they bring all the ER run sheets. So we look at our run sheets, and then we have our PRC peer review committee. And then we have trigger points, that the indicators, which all of you know about. We all probably use the exact same indicators, and I won't go through this list. But just as an example, I'll get a call from, the neurosurgeon, well, they had a stroke. Why are you reviewing that case? Because it's an indicator. I know you didn't do anything wrong, I think, but we'll review it and see. But when you have a list of what you review and you can say, I'll shoot you a list of the indicators, that kind of calms them down. I'm not picking on you. This is what happened, and we review these things. So you have to have a list of what you're going to review, stick to it, and you can add to it. So if there's something, we added what's called case by case up here. That way it's a case by case. What does that mean? It's case by case. So, but if you have your list, you stick with your list. And if you need to review something, then that's what you review. Whether you review decubitus ulcers or whatever it is, but this is the list that we use, and we stick with it. And if something comes up, we add it to it. And then so our PI program, usually the issues are almost like what Codman said, if you go back to his writings. It's either a physician issue or a non-physician healthcare provider. That could be a respiratory therapist, a nurse practitioner, the physical therapist. It's a system issue. We kind of all messed up in different places or on different paths. And the ubiquitous communication issues, which often falls into the 3 above. And then we rate things, level 1, level 2, nothing major, just some little minor things. Level 3 is an opportunity for improvement, and that could be with anything in technique, judgment, communication, professionalism, whatever that opportunity is, there's an opportunity for improvement. Multi non-1, non-2 just means the committee can't render a decision on the hand surgeon because nobody in the room was a hand surgeon, so we'll send it back, but we don't think it's a level 1 or 2. We think there's some opportunity there, and we send it off, and they have to report back to us. And you never want to have a level 4, which means the care was completely unacceptable, fell out of the rim of the norm in any hospital. No doctor would stand up and defend you, and you never want to have a level 4. But I cannot say we've never had one. All right, so these are just some of the 2013 PI initiatives that came out of this year. And really the list is this long. I just pulled some up. In 2013, an unplanned intubation, readmission to the ICU, who ended up getting intubated, et cetera. I'll talk a little bit about that case. CVA, stroke, early recognition, which went on for us to develop a stroke certification, which we have now. Issues with death and PE, I think we've been dealing with this. I remember as a medical student, death and PE, we still haven't figured it out 100%. We're doing better. Unplanned return to the ICU, death from an exsanguinating patient, some miscommunication between the trauma surgeon and anesthesia dropping off a patient who got 4 units of blood and nobody knows. And so now we have a protocol. You don't do that anymore. You get blood in the OR, even if it's 1 unit, whoever's in the unit should know about it, etc. Just some quick 2014 PI initiatives. A lot of issues with glucose control when I first got to John C. Lincoln, mainly with type 1 diabetics. You know, they'd come in and I manage my own glucose. I have an insulin pump. Okay, that's fine. But you didn't undergo anesthesia when you were at home, and you didn't break your leg, and you might not can manage your own insulin in this hospital after morphine, et cetera, et cetera. Some issues with TXA, MTP, pelvic binders, and you can read some of these things. Rome patient taken to the OR, you know, just little things like the neurosurgeon happens to be seeing a patient in the ICU, and he calls the OR, hey, I'm ready to go, let's get this patient to the OR. They think he means this patient. He's talking about the patient down in the ER, and they start rolling, and we're like, wait, nothing happened. We didn't even make it out of the ICU. But that could have been a tremendous issue. That patient never made it to the OR. But little things like that should be a flag for a PI issue. 2015 PI initiatives, you know, we had issues with mangled extremity, decreased time to OR, because we were trying to reverse anticoagulation, which ultimately resulted in a PCC protocol. And we've actually have a publication in Society of Critical Care Medicine 2 years, a year and a half or so later after this PI issue. And you can see some of the others. MTP, we had a lot of issues with MTP over the years, and again, another PCC protocol. Which brings us up to 2016, PI initiatives, central line placement. You can read these, another diabetic care, you know, resuming home meds, you know, some epic things, etc. So just to review a few, so the case that was an unplanned intubation way back in 2013, readmission to the ICU, was a patient who had, you know, too many rib fractures to go to the floor, but they went to the floor, ultimately came back to the unit, ultimately ended up intubated and developed a pneumonia. And this is the sheet we use, and so we usually under here, we write the case, a 55-year-old man, da-da-da-da-da. And then what was the outcome? The outcome, did he live, did he die? And then what was our action, or what was the first, this is what was our impression, and then what was our action or our loop closure, and then we give it a rating, multi-level 1, multi-level 2, level non-192, you know, et cetera, et cetera. So as a result of this case, you know, we developed our rib fracture pathway, and patients over 45, based on the data, came to the ICU at least for 24 hours if they had more than 4 rib fractures. At that time, we were considering rib plating, and we made sure that, you know, before they leave, they get a chest x-ray, because we had a patient come back to the ER with an effusion, et cetera, but he hadn't had a chest x-ray before he left for 2 days because he looked so good. And so as a result, we came up with our protocol, which if many people have seen this. We've just made some addendums to the protocol. And basically, I won't go through it all, but, you know, either whether you come to the unit or you don't go to the unit, you know, pain management, we were placing on cues, or epidurals, respiratory therapy, everybody got easy PAP, PTOT early, consider rib plating early if applicable. And then on the other side, you know, in the IS volume, pain control, and cough, and some of that's subjective, but at least we had something that we could look at, and we had kind of assigned one of our nurse practitioners to make sure we're following the protocol. And so we did that, and then over time, as a result of that PI issue back in 2013, we ultimately moved to, you know, a lot of people were against these big incisions to do rib plating. I was one of those, unless it was just a horrible case. Now we're looking at the data, but I mean, I've plated 4 ribs with an incision like this. Don't cut through the latissimus dorsi. You may have to split the serratus. They have nice little gadgets where you can put that 90-degree screw. And case that used to take us 3 hours, we've done our fastest is like 46 minutes. So it can be done, and you can make one incision here and one incision there. You don't have to go spread everything. And I think this is going to change the way everybody manages rib plating once the data comes out. And we gave it a name, MISMIT. Francis doesn't like to say MISMIT. Maybe I should have made it Mr. MIT. You notice he always says muscle sparing, minimally invasive thoracotomy. I just call it MISMIT procedure. But we collected our clinical data. So Francis, Dr. Ollie Osmond, went through every patient that we did. We have our own data bank for rib plating, because we can't do something if we don't prove, at least to the best of our ability, what the outcomes look like. So we presented the pre-op pulmonary function test and post-op, because that was something sort of tangible that we can lay our hands on. And now we're looking back at historical controls that didn't get plating and try to match those as best to the best of our ability versus those that did. And this is clinical data that the hospital can't give you. They're just going to say, well, they're staying longer. Or are they staying longer? Or, I don't know. And then when you show them this data, they're like, oh, you have all that? Yes, we have all that. And then so we've been presenting this data. Another case, again, these are our sheets where we present the case here, and then we have our outcomes, and then we give it to somebody to review, and they give their impression, and then we make action loop closure at the meeting, and then we rank it. So this was a patient who had a history of DVT, was found down. I think she had a hip fracture, or pelvic fracture, but she had a fracture. We don't know how long she was down. Anyway, ultimately, the patient died with a PE. She went to the floor, et cetera, a lot of learning with that. As a result, we started reviewing the literature, and then we have under our trauma drive, we have what's called the S drive, and anybody can go to it. Any trauma surgeon, if you take care of trauma patients, and you can see what's the literature we've been reviewing, and what are we referencing, and we keep that, and we make it available. So this is what we look at, and then we come back to multi, and we say, hey, we're going to develop a protocol. We can argue back and forth, or if you look for them, you'll find them. If you don't, you may have more PEs. Well, we decided as a result of some of the cases that we had, we should have at least a screening protocol for the highest risk patients. And that's what we did. We developed a protocol for the highest risk trauma patients. We had some issues, I think everybody does, in every trauma center, with taking hypotensive patients to the CT scanner. You would think that we would never do that again, but trust me, we do. And some of my colleagues are like, oh, we resuscitated the CT room. So those are still issues. And so as a result of, we had a patient like that with a positive FAST, hypotensive, but because their pupils were fixed and dilated and they were convinced this was a head injury and that was going to kill them, and then we just wanted to go to CT to see if it was salvageable. And you know what happened in CT, starts coding and arresting. Yeah, they might have a head injury, but if they're hypotensive with a positive FAST, you got to go to the operating room. And so, a lot of discussion with that, difficulty in monitoring patients going from CT to the OR with blood. Even though blood's hanging, they're hypotensive, they're hemodynamically unstable, instability. Of course, there was an opportunity there to reduce mortality by taking unstable patients immediately to the OR and then run them through CT. And then, of course, it's this whole time delay. We had a big grand rounds, can we decrease mortality in an effort to close the loop. MTP, everybody probably has some MTP issues. I mean, the American College of Surgeons, COT, tried to help us as well. We had the same thing, so this was another case where we felt everything was done appropriately from a surgeon, nurse standpoint, but the system kind of failed. One of the coolers ended up in IR because they heard the patient was going to IR, but the patient was still in the OR, et cetera, et cetera. So there were some system issues with this. And so this sparked a lot of discussion, do we give 1-to-1-to-1, do we give 1 to 2-to-1, what do we put in the cooler, 4 units of blood, 6 units of blood, 4 of FFP, 5 of FFP, do we add TXA? Lots of discussion, which is really good, which is what your PI program should do. All the initiatives, even like I said, TQIP came out with their MTP thing. We're trying to make it easy on everybody. Use the ABC score, not airway, breathing, circulation, but assessment of blood consumption. If the patient's tachycardic and their systolic blood pressure is less than 90 and their FAST is positive, you should initiate your MTP protocol and take some of the guesswork out. And I tell the residents, if you got a patient coming in your ER and they're not a kid, their heart rate's 140, something's wrong. I've been on a treadmill to get my heart rate up for a stress test, and he had the incline like this, how much time? So that we knew, so just to get my heart rate up. So that's not normal. So anyway, with MTP, all these processes happened, and we ultimately, did I go backwards? Yeah, I went backwards. Oh, I'm still going backwards. It's because PJ startled me. So we, had some meetings, and, again, we started looking at every MTP case for the month, put it on our portal, everybody could look at it, and then we activated, we created our own protocol where we initiate MTP, pager goes off, the house supervisor's in charge of getting the blood to the right place, et cetera, and everyone should have this high sense of urgency. If the pager goes off MTP, everybody should sort of say, hey, somebody's bleeding in our hospital. I talked about the diabetes issue, so I won't go through that. Had a lot of issues with, especially type 1 diabetes, and if their glucose was over 250, their case was canceled, and, coming back to the ICU for control, et cetera, et cetera. And we came up with, sort of a protocol, but ultimately, now we have this Epic Glucomander. I don't know how many people have Glucomander in their hospital. And I don't know if we really close the loop or if we're going to close the loop. It's hard to say. Just some other issues with pelvic binders. The new one is now wound care issues because I have some young trauma surgeons who did a burn fellowship. So I just told them, every wound you do, you collect every single variable so that we can look at the outcome. Should we be doing wounds here or should we not? These are just some of the protocols that we've developed over the past 3 years or so, and you can kind of see those, but I can also share. All these slides are shareable. None of this can happen without a big team and a dedicated team. This is Merlin. She does all our PI, so she's sort of the boss of me. And then I'm going to skip that slide because that'll just make you laugh. So closing the loop, there's issues with exposing the physician, issues with exposing the system, financial considerations, liability issues, regulatory and compliance issues. We have this disruptive technology that we're all dealing with. This is even disruptive technology. So, the obvious change in disruptive technology is, in surgeries, large incisions to smaller, quick recovery, shorter hospital stays. But this disruptive technology is not just limited to medicine and surgery. We got Uber now, we got robotics, we have all these things, smartphones, anything that can be miniaturized, we miniaturize it. And all this disruptive technology has led to new things that we have to deal with, EMR and electronic medical records, new imaging modalities, percutaneous everything. I should have put IR everything. They want to send them to IR to embolize an intercostal, laparoscopy, just everything. So the future of PI and quality, we need continuous improvement. We have to keep up with technology. Healthcare must embrace standardization of processes. Of course, we need skilled leadership. And we have to have there are drivers of quality that we all have to deal with. I don't know if we close the loop in every case, but I think you have to do your best. For me, when I say, did we close the loop, I'm asking myself, did we put something in place so that if another person walks into this hospital, that won't happen again? That's my definition of closing the loop, and thank you very much.